All right, in this one, we're going to talk about one of my favorite topics. This is the pulmonary renal syndrome. I really like this topic because it includes a lot of the kind of mysterious rheumatological diseases that really take a lot of time and practice over and over again to kind of recognize and understand kind of the pathophysiological processes that are going on. This is a relatively high yield concept. As you've seen probably on step exams and studying, there's a whole category called multisystem disorders. And it tends to be one of the aspects of these exams that students score kind of low on because these multi-system disorders are quite complex, and being able to put together, is this one syndrome that's causing this? Are there multiple things going on? It takes, again, a lot of time and practice. But the pulmonary renal syndrome, relatively high yield, it's an important concept to know. All right, so we'll discuss the pathophys of pulmonary renal syndrome. We'll discuss the presentation, the main etiologies, the core workup and management, and then we'll do a putting it all together question. So, case to consider, we have a 60-year-old woman with no significant past medical history. She presented to the ED with a 2-week history of fevers, polyarthralgias, and progressive dyspnea. She reported the recent onset of hemoptysis and noted spreading purpuric rashes over her lower extremities. She denied any recent infections, sick contacts, or new medications. On exam, she appeared acutely ill with tachypnea and oxygen sat of 88% on room air. Her blood pressure was 165/95. Physical exam revealed bilateral crackles on lung auscultation and palpable purpura on the lower extremities. There was trace bilateral pedal edema. Her lab study showed a hemoglobin of 7.2, so her baseline was 13.5. Serum creatinine of 4.8, her baseline 0.9. Urinalysis with 3 plus protein, 3 plus blood, and numerous RBC casts. And then I've got your chest x-ray on the next slide. Take a look at that chest x-ray, and I want you to tell me, what is the next best step? Should we do a bronchoscopy? Should we do a chest CT without contrast? Should we do thoracentesis, or should we do upper endoscopy? So pause your screen, take a look at the chest x-ray, and I'll go back to, you can take a look at the labs again too in our case, and then we'll discuss. All right, so in this case, this is very concerning, obviously, for pulmonary renal syndrome, but we have to understand what to do next, right? So with pulmonary renal syndrome, when there's concern for diffuse alveolar hemorrhage, which we'll talk about in a little bit, we need to do a bronchoscopy, okay? So a bronchoscopy with a BAL, a bronchoalveolar lavage, is the next best step. So essentially what this is, a bronchoscopy, we're going to stick a tube down the patient's trachea into the bronchi, right, into the alveoli, and we're going to be able to do a BAL, which the physician is going to kind of shoot water in and then take water out, and we'll look at the sample that comes back, okay? To diagnose diffuse alveolar hemorrhage, right, we need the clinical kind of picture that we've got going on here, right? The patient has hemoptysis. We see on this chest x-ray, which we'll go through in a second, with diffuse bilateral pulmonary infiltrates that could be concerning for diffuse alveolar hemorrhage. And then the key thing is on a BAL, as we keep taking fluid out of the lungs, right? So we kind of essentially shoot water in and then take fluid out, right? That fluid is going to be progressively and sequentially bloody, okay? So if it was like a small little bleed, we might see like the first sample come back bloody, and then as we keep going and diluting out some of this blood that might be kind of in the alveoli, the blood will come back less and less and less, right? Every sample we do. For a patient with diffuse alveolar hemorrhage, right, every sample we're going to take back is just going to be progressively and sequentially bloody, right? Because this is a massive bleed going on, right? So I've got it kind of written here, right? Persistently or progressive bloody return on sequential BAL or hemosiderin-laden macrophages on cytology will confirm that diffuse alveolar hemorrhage, okay? And so what we can do, right, when we look at this chest x-ray, right, there's a systematic way to go through a chest x-ray. We could do kind of the A, B, C, D, E, where A is the airway, right? So, and this chest x-ray, it's not the best, right? There's a lot of stuff going on, but the airway, you can kind of see the trachea is still down the middle, right? So it's not kind of off to one side or the other, right? So remember, like things like a big tension pneumothorax can push the trachea to the opposite side, and something like resorptive atelectasis can push the trachea towards the side of the atelectasis, right? So then the B is bones, right? And so you can look at the bones. Again, it's kind of hard to see here, but you kind of look for fractures. You look for things that might be out of place in the bone. You can kind of count the ribs to see if you can see all the ribs that should be available. And again, nothing kind of abnormal there. The C is the cardiac silhouette, right? And again, it's very hard to see on this X-ray, right? Usually we think about if the cardiac silhouette is greater than 1/2 the distance between kind of my midline to the end of my body out here. So if it's more than 1/2, that's when we kind of consider cardiomegaly. Okay. And again, very hard to see here. But you can pick up on cardiomegaly. You could pick up on, the cardiac silhouette being abnormal in shape, which might key you in on certain diagnoses. The D is the diaphragm. So normally we should be able to see a nice demarcation of the diaphragm here. And again, where my kind of lung fields meet the diaphragm, that angle right here is called the costophrenic angle. And again, in this one, it's pretty hard to see. But when I have blunting of that costophrenic angle, that could be a sign of pleural effusion, right? So that's a classic buzzword, classic finding on a chest x-ray where you have blunting of the costophrenic angle is sign that there's fluid built up in that pleural space that's kind of gravity dependent and it's just sitting in that costophrenic angle. And so we can't see it as sharply demarcated on a chest x-ray. Okay, so that's the D, and then the E is everything else, right? So that's where we actually look in the lung fields. And here, again, we see diffuse bilateral infiltrates, right? I was recently on an ICU rotation where you work with the intensivist and the pulmonologist, and I had a really good physician, one of the attendings, who told us, hey, like on a chest x-ray, right, you see something like this. You don't necessarily know what it is, but you can kind of base your differential off of it being pus, blood, water, or protein, right? So it's kind of one of those things, right? Pus, blood, water, or protein. When you see something like an infiltrate, okay? And so in this case, right, the patient's having hemoptysis. We're quite concerned for it being blood, right? Blood in the lungs where it should not be, right, in the parenchyma. And so along with this, right, when we go back to our patient history, they have some of these signs and symptoms of potentially a diffuse rheumatological disease, right? So we see they have a 2-week history of fever, polyarthralgia, so joint pain, progressive dyspnea. They also have this purpuric rash, right, which is classic for small vessel vasculitis, okay? So really, I'll do a whole lecture on vasculitis. That's not the purpose of this lecture. This lecture is to kind of key you in on signs and symptoms of pulmonary renal syndrome and what are like the major causes. And some of the major causes are small vessel vasculitis, which we'll talk about. But small vessel vasculitis, what a vasculitis is it's essentially inflammation of my vessels, right? And then that inflammation builds over time. It causes constriction, it causes inflammation, and we cut off blood supply to some of my end organs, okay? Some of these vessels in the small vessel vasculitis, right, we're going to impact the vessels of my gravity dependent areas on my body, like my butt, my thighs, my legs, and we can cause inflammation and extravasation of fluid out of the vessels, and then we can cause what's called palpable purpura, right? So it's really important when you're like looking at a rash on a patient that has it in the gravity dependent area, it's important to differentiate your purpura versus petechiae, right? So your purpura, it should be in a small vessel vasculitis. It's going to be palpable. I can run my finger along the purpura and I can actually feel the bump. When it's petechiae, right, we have a lack of platelets, right? Platelets are really important for primary hemostasis, and especially in my small little vessels. When we don't have that, right, the vessels can kind of bleed easily, right? And then we can get these petechiae that show up as pinpoint hemorrhages all throughout the body, right? But when I have a petechiae, if I run my finger across that, I shouldn't be able to feel a bump, right? So just based on physical exam, I can almost differentiate, a palpable purpura, I can feel the bump versus petechiae, okay? Also, right, we could do, labs, right? Again, some of these vasculitis and some of these rheumatological conditions can have abnormalities in CBCs, but obviously to have petechiae, clinically significant petechiae, you would likely have to have either low platelets or malfunction platelets, right? So we could do that whole workup as well. But again, when I see this woman, she's got fever, she's got malaise, she's got polyarthralgias, she's got dyspnea, and then we look at her renal function, right? First off, her hemoglobin's dipped way down, right? Probably from this hemoptysis and losing blood in the urine. And then we see her serum creatinine is sky freaking high. compared to what it was normally. And then we see 3 plus blood, 3 plus protein, numerous red blood cell casts, right? Whenever I see red blood cell casts on a urinalysis, that is essentially pointing me towards some form of glomerular nephritis, right? So remember, with glomerular nephritis, we have inflammation and damage to the glomerular basement membrane that is allowing red blood cells to leak through the glomerulus into the nephron itself, right? And red blood cells really should not be in the nephron. And when they make their way into the nephron and the tubular system, the red blood cells don't fit really appropriately, right? Because they're not supposed to be in there. And so when they don't fit appropriately, they kind of sloth against the wall, they get stuck, and they form these big old red blood cell casts that we can see on urine microscopy, okay? So red blood cell casts are essentially almost pathognomonic for glomerular nephritis. So when I look at this patient, right, let's put the picture together. We see fever, polyarthralgias, dyspnea, malaise, right? Kind of concerning for some aspect of systemic rheumatological disease. She's got the palpable purpura, right? Palpable purpura is definitely not a specific finding, but it is relatively common in some of my small vessel vasculitis, like a GPA and MPA, EGPA, things like cryoglobulonemic vasculitis, right? Things along those lines. It's kind of that when I see palpable purpura, it kind of points me that way. And then I see, okay, she's got diffuse alveolar hemorrhage and she's got glomerular nephritis, right? And so in this case, I need to do a bronchoscopy because I need to do the BAL to see, okay, is this actually diffuse alveolar hemorrhage, right? We can't make the diagnosis based on a chest x-ray. We need to see that the BAL comes back with progressively and sequentially increased amount of blood, right? So that's kind of the way I work through this question. Thoracentesis would be a good option if this were pleural effusion. Upper endoscopy would be a good option if this were a upper GI bleed. And chest CT without contrast is not going to show us really anything more than we've got here, right? It would just be an extra imaging test that would just delay, getting the definitive diagnosis and management. All right. So again, what is pulmonary renal syndrome? It is the diffuse alveolar hemorrhage plus rapidly progressive glomerular nephritis, right? So it is the DAH, capillaritis, alveolitis, right? So inflammation of the capillaries, inflammation of the alveoli, causing a diffuse alveolar hemorrhage, plus the rapidly progressive glomerular nephritis, right? So we would see crescents on kidney biopsy, which we'll talk about in a second, right? So when you get the mixture of both of those, DAH plus RPGM, we're concerned for pulmonary renal syndrome. It is a medical emergency with very high morbidity and mortality. We treat it while we are diagnosing, right? This is why it's a really high yield step exam question, right? Because one, it's multi-system disorder, right? So it really makes you think. USMLE, MBME, they love those types of questions. But two, it's a medical emergency, right? So, you're an ED provider or you're an internist who's taking over this patient, or you're a family med doc and this patient presents you outpatient, right? You have to understand, how do I triage this patient? What do I do, right? So it's a really high yield concept for almost like all fields of medicine. So the core concept, right? This is a unifying lesion, okay? It's a small vessel inflammation or capillaritis, right? Inflammation of the capillaries that tends to be autoimmune, and it's hitting both the lungs and the kidneys, right? So we're impacting the small vessels in my kidneys and we're impacting the small capillaries in my lungs, right? Remember, like, this is a syndrome. It's not essentially like a single disease, right? So it's like we really need to identify the etiology fast, right? So there's something I usually like to teach my students. There's a couple different ways to think about it, right? There's Occam's razor, and then there's Hickham's dickum. Whenever you think about a patient with multiple problems going on, so Occam's razor is essentially saying the simplest explanation is the most likely, right? So in this case, with a patient who has diffuse alveolar hemorrhage and rapidly progressive glomerular nephritis, the Occam's razor would tell you it's caused by one thing, right? One thing is the simplest explanation. Could there be one thing that would explain both the diffuse alveolar hemorrhage and the rapidly progressive nephritis? And then there's Hickham's dickum, which is essentially saying the patient can have as many problems as they well please, right? So in that case, you would argue, okay, they have diffuse alveolar hemorrhage for X, and they have rapidly progressive glomerular nephritis for Y, right? In this case, I want you to recognize the combination of DAH plus RPGM, especially in the setting of a patient with systemic rheumatological manifestations such as fever, malaise, dyspnea, weight loss, right, palpable purpura, you want to consider this is one syndrome, pulmonary renal syndrome, and then we'll talk about the etiologies that could possibly cause that. Okay, I think that's a really important concept for you guys to think about, like for the rest of your life, right? When a patient presents with multiple problems, is there a way I can unify these problems into one succinct story, right? One beautiful story that I could tell to explain everything, or could they have multiple things going on, right? I'll tell you, for at least for the sake of step 1 and step 2, there's usually one unifying story, right? In real life, it's usually almost never that simple. But for like step 1, step 2, it's usually likely that there's one kind of story going on, right? You think about, like, this is an aside, but you think about a patient, like a younger patient, let's say they're 30-year-old, who has new bibasilar COPD, right? We got chest CT, we did spirometry, we've kind of made our diagnosis. They're 30, they've never smoked, they've got new bibasilar, like, so really like gravity dependent COPD, and their liver enzymes are elevated, and they have a family history of liver cirrhosis, right? Non-alcoholic liver cirrhosis. And you think to yourself, okay, could they have COPD for X reason and this liver damage for another reason, right? And then you kind of take a step back and you're like, well, they've never smoked and they're really young. It's kind of odd for them to have a COPD. And then you remember, okay, bibasilar, that might mean something if they don't have like diffuse COPD, it's just bibasilar, and they have the liver dysfunction. You put the clinical picture together and you think to yourself, oh my God, could they have a SERPINA1 mutation, right, leading to alpha 1 antitrypsin deficiency that would explain both their liver dysfunction and their bibasilar dependent COPD, right? So that's like an example of using Occam's razor. Okay, little aside there. So 3 big buckets for pulmonary renal syndrome, right? Whenever you have a patient with pulmonary renal syndrome, it's essentially should fit into one of these buckets. We have our ANCA-associated vasculitis, or what's called pauci-immune glomerular nephritis, right? All that means is it's like a fake immune complex, right? It's not essentially immune complex. It's formed by these ANCA-associated vasculitis, right? So the big ANCA-associated vasculitis you need to know are GPA, MPA, and EGPA, right? So EGPA and MPA tend to be p-ANCA positive, right? That is autoantibodies associated with the perinuclear portion of these neutrophils that overactivate them, right? And these antibodies tend to be what's called myeloperoxidase positive, okay? If we did immunofluorescence, they would most likely be myeloperoxidase positive, right? It is far more complex than that. If you want to become a rheumatologist, right, there's so many nuances to that. But for the sake of step 1 and step 2, if something is p-ANCA positive, I have never seen them not be MPO positive, right? Or vice versa, okay? That is for the sake of step 1 and step 2. I just want to reiterate, in real life, it is far more complicated than that. That is why rheumatology is a 3-year fellowship. And so you can kind of learn the minutia of this, right? But again, MPA, EGPA tend to be p-ANCA positive and then MPO positive on immunofluorescence, right? And then GPA, granulomatous with polyangiitis, tends to be c-ANCA positive, right? So it's antibodies associated to the cytoplasm of these neutrophils, and then those tend to be proteinase 3 ANCA positive, right, on immunofluorescence, so PR3. So really, in like as succinctly as possible, because I'll do a whole vasculitis lecture to kind of differentiate your large, medium, and small vessel vasculitis. But these are all examples of small vessel vasculitis. GPA and MPA are often quite similar, okay? They tend to impact the upper respiratory tract, the lower respiratory tract, and the kidneys, right? So upper respiratory tract, you could have recurrent otitis media, sinusitis, epistaxis, right? And GPA, they can actually get that saddle nose due to destruction of some of the cartilage in the nose, okay? Maybe like recurrent dental caries could be another example of kind of upper respiratory tract, or just chronic like upper respiratory tract infections. Your lower respiratory tract examples would be like things like bronchiectasis, right? Chronic like pneumonias, right? Things along those lines, hemoptysis, right? And then the kidney manifestation would be glomerular nephritis, right? And potentially RPGN. The way we kind of differentiate MPA and GPA would be biopsy is one of them, right? So GPA is granulomatous with polyangiitis, right? So on biopsy, we would potentially see granulomatous formation. In MPA, it's non-granulomatous, right? And then our serology can help us tell them apart too, because GPA tends to be c-ANCA PR3 positive, MPA tends to be more likely P-ANCA, and then MPO positive, okay? And then EGPA tends to be a less common cause of diffuse alveolar hemorrhage and pulmonary renal syndrome, but it can still cause it, right? So you're going to want to think about a patient with EGPA who has a history of some of my atopy, like atopic conditions, things like asthma, allergic rhinitis, dermatitis, right? Or a family history of those, okay? And again, it tends to cause, potentially the upper respiratory, some lower respiratory, and some glomerular nephritis. It's a little bit kind of a trickier disease to diagnose. But what you're going to want to think about in a vignette is a patient with a history of asthma, allergic rhinitis, dermatitis, who's presenting with chronic upper respiratory tract infections, lower respiratory tract infections, palpable purpura, glomerular nephritis, and then EGPA often is a cause of what we call mononeuritis multiplex, which is inflammation of some of my small nerves, classically like in the wrist and the foot. So they might have wrist drop, they might have foot drop. And then you'll get your CBC with differential, and they'll have elevated eosinophils. Potentially, if you get IgE levels, those would be elevated. And those would all be signs and symptoms to kind of key me in on a diagnosis of EGPA. So again, this is called pauciimmune, because if we did a kidney biopsy and we saw the crescents, we wouldn't see immune complexes, right? We'd see these ANCA manifestations, right? So that's what it essentially means by pauciimmune, okay? Then there's antiglomerular basement membrane disease, or what we call Goodpasture disease. You're going to want to think about this, right? This is a disease where it's autoantibodies. It's a type 2 hypersensitivity. So remember, type 1 is IgE mediated, type 2 is autoantibody mediated, type 3 is immune complex mediated, and type 4 is my delayed T cell reaction, right? Delayed T hypersensitivity. So anti-glomerular basement membrane disease, or Goodpasture. Type 2, we have autoantibody formation against type 4 collagen that is primarily found in both the kidneys and your lungs, right? So you'll see a patient with hemoptysis and hematuria, potentially glomerular nephritis, and this is a disease that classically impacts men, anywhere between 20 and 50 years old, right? The literature will kind of throw you all over, but what I've seen over and over and over again in questions and from my own reading is it's classically, you should think about this, in a male 20 to 40, 50 years old who has hemoptysis and hematuria, right? That's when you want to think about Goodpasture disease, okay? It's different from Alport syndrome, right? Alport syndrome is a genetic mutation in the type 4 collagen that can then cause, renal manifestations, and it can cause eye and ear manifestations, right? So those patients tend to have sensory neural hearing loss and vision disturbances, right? Because it's type 4 collagen, but it's a different aspect of the type 4 collagen compared to antiglomerular basement membrane disease, okay? So really just remember anti-GBM, hemoptysis, hematuria, relatively younger male, right? That's when you want to think about it, okay? We'll talk about diagnoses for that in a second, but really we would test for anti-GBM, right? And then if we did a kidney biopsy, we should see linear IgG on immunofluorescence, right? That's the classic buzzword, okay? And then immune complex glomerular nephritis, right? So this is essentially a type 3 hypersensitivity. Immune complexes can be formed via so many different aspects, right? I just gave you a couple of options, right? Lupus is a classic cause of immune complex deposition. IgA vasculitis is a classic cause of immune complex deposition, right? That can lead to our formation of pulmonary renal syndrome. Cryoglobulinemia, right? Cryoglobulinemia, there's 3 types essentially. For the sake of step 1 and step 2, you want to associate cryoglobulinemia with an underlying hep C infection, right? So these patients will likely have palpable purpura. They could have mononeuritis multiplex, so wrist drop, foot drop. They could have signs and symptoms of systemic vasculitis, so fever, malaise, weight loss, right? Things along those lines. And then you'll see their liver enzymes might be elevated, or they'll tell you they have a history of hepatitis C infection, or they'll ask you, what should we order? We should order hep C antibodies, right? And hep C RNA. And then there's infection-related glomerular nephritis, right? So infection is a common cause to stimulate immunocomplexes as well, right? The list goes on and on and on. But in this case, we get immune complex deposition in the kidneys and in the lungs, right? In the capillaries, the alveoli, that can then lead to hemoptysis, hematuria, and then essentially pulmonary renal syndrome, right? Our deadly condition, okay? So that was kind of as brief but also in depth as I could give. I will do a separate lecture on kind of all these things at another time, okay? Because these are all relatively high yield. So wide, steadily, right, diffuse alveolar hemorrhage, we get hypoxemic respiratory failure, and sometimes these patients can even present without hemoptysis, right? So getting imaging and doing a BAL is really important, right, to kind of key in on this, okay? The RPGN, rapidly progressive glomerular nephritis, can occur in just days to weeks, right? And then we'll see on kidney biopsy the crescents, made up of macrophages and fibrin, and then whatever is causing this problem, right? Whether it be the posse immune complexes, the anti-GBM, right, the linear IgG on immunofluorescence, or is it an immune complex, right? And if we delay in immunosuppression or plex, right, it worsens outcomes. I've talked about with a lot of my students at Medical College of Wisconsin, we always talk about like TTP, right? TTP has such a weird presentation, and if you miss it, right, the patient could die, right? So I think about pulmonary renal syndrome in a similar aspect, right? We need to have a very high suspicion for pulmonary renal syndrome so we can catch it, okay? And then the sooner we're able to initiate proper management, the better the outcomes will be, okay? So clinical suspicions, we've already kind of talked about this, right? Dyspnea, cough, hemoptysis, right? Pleuritic chest pain. Clues, they have a falling hemoglobin, right, due to or coughing up blood, peeing out. And remember, hemoglobin is a concentration, right? It's a concentration of the hemoglobin in my blood, right? So if the patient were to cough up blood and pee out blood, and we haven't given them any intravenous fluids, and they haven't had any interstitial blood or interstitial fluid kind of move back into the intravascular space, their hemoglobin may be normal, right? Because they're coughing up blood and your plasma, right? So it's a concentration. We're coughing up the same amount of hemoglobin for the same amount of plasma. So if we haven't given them any intravenous fluids, and we haven't given it enough time for the body to compensate by drawing fluid from the interstitial space back into the intravascular space to increase my pressure throughout my system, right? Their hemoglobin may read as normal, okay? So you have to have a high clinical suspicion, right? You don't just base it off of the hemoglobin as to if they're having an acute bleed, right? You have to do a good physical and history, okay? Then we might see new diffuse infiltrates on chest x-ray or CT, rising O2 requirements. Imaging, we'll see a chest x-ray or CT with bilateral ground glass or alveolar opacities. Again, it's non-suspicious, specific, right? Could be pus, blood, water, protein, right? So we could have edema, we could have infection going on, right? Remember, your classic buzzword and finding on a chest x-ray for pneumocystis jirovecii pneumonia is diffuse interstitial bilateral infiltrates, right? So we got to see, does this patient have HIV? Do they have a clinical picture that's kind of concerning for PJP pneumonia, right? A lot of things in this differential. But then if we look at the kidney function, right? If we see hematuria, proteinuria, dysmorphic RBCs and RBC casts, okay, now we're thinking lungs and kidneys are impacted, right? Potentially we have a pulmonary renal syndrome, okay? We'll see rising creatinine, rising BUM, possibly hypertension and edema due to kidney failure. And then I want you to consider RPGM when the renal function worsens rapidly over days to weeks. All right? So immediate stabilization, ABCs, airway breathing circulation. We give oxygen. We can do high flow nasal cannula or intubation as needed. If they're in shock, we have to treat the shock. That's a discussion for another day. We transfuse if needed, right? Correct a coagulopathy if it's present, right? And then infectious coverage, right? If we're concerned for infection, we can treat for community-acquired pneumonia or whatever else we kind of think is going on. And then early consults, you're going to want to talk to the ICU, nephrology, and your room and palm colleagues, right? They'll help you kind of get settled, and they'll help run the management here, okay? Diagnostic workup, CBC to look at their hemoglobin, CMP and creatinine, a UA with microscopy, a urine protein quantification. We can get coags, we can get ESR and CRP, which will likely be elevated, right, if this is a systemic rheumatological disease. We can get a type and screen if we have to transfuse. Rule in and rule out. So remember, these tests might take a little bit of time, okay? So we're going to diagnose and treat as we go, right, if we have a high clinical suspicion. So we get my ANCA, my PR3, MPO, anti-glomerular basement membrane. We can get an ANA, a double-stranded DNA, anti-Smith. We can get C3 and C4, cryoglobulins, hepatitis, HIV, right? So C3, C4, if those are low, those tells me there's likely some aspect of immune complex deposition, right? Because immune complexes tend to activate the complement, we'd use up my complement C3 and C4, or at least one of them might be a little bit low, right? That's classic for cryoglobulinemic vasculitis, is the C4 tends to be low. And again, we can test for some of these viruses as well. Imaging, chest x-ray rapid, we can do a CT if they're stable. We could consider an echo if concerned for cardiogenic edema. All right, further workup, right? We have to get that bronchoscopy with BAL. Progressively bloodier aliquots supports a DAH, and it helps to exclude an infection, okay? We'll do a kidney biopsy, which is often going to give us the highest yield. Obviously, we're not going to do it if the patient's unstable. We'd have to wait, right? But the kidney biopsy is going to be the highest yield. So we could see pauci-immune crescents, right? Would key me in on, okay, maybe this is oncovasculitis causing pulmonary renal. Linear IgG along the glomerular basement membrane. Okay, maybe this is Goodpasture syndrome. Or we see granular deposits, right? So immune complex disease, right? So that would be my type 3 hypersensitivity. Treatment overview. For the sake of step 1 and step 2, right? It's again, if you're a rheumatologist, even a hospitalist, you're going to need to know like more in depth than this. For the sake of step 2, right? We think about it's almost steroid plus an induction agent. That's essentially what I want you to get at here. So a high dose IV steroid plus an induction agent. The induction agent tends to be either cyclophosphamide or rituximab, right? I would probably stop there, right? That's for like the vast majority of these pulmonary renal syndromes. For the sake of, honestly, they're not even going to ask you treatment on step 1. They'll probably ask you what is the possible diagnosis or pathophysiology, right? And we've kind of talked about the oncovasculitis, the anti-GBM, and immune complexes. So you have enough information, you could answer that. For step 2, it's a fair question to ask how to treat. IV methylpred and an induction agent, so either cyclophosphamide or rituximab. For the sake of anti-glomerular basement membrane disease, there is data to suggest we should probably do what's called triple therapy, where we do steroids plus cyclophosphamide plus plasma exchange, right? Just like we would do for TTP. The reason being, right, in anti-GBM, it's autoantibodies that are causing all this destruction. So in plasma exchange, I can remove the antibodies and give back normal plasma, right? It's just like in TTP, where I have autoantibodies destroying ADAM-TS13. So I need to do plasma exchange to remove the bad antibodies, and then we give back normal plasma. And in that case, the normal plasma has normal functioning ADAM-TS13. So same idea here, right? So for pulmonary renal syndrome, just think IV steroids plus either cyclophosphamide or rituximab. And then if it's anti-GBM, add on plasma exchange, right? That would be for step 1 and step 2. That would be the length I would know. Plasma exchange, again, it's really quite nuanced. You're not expected to know this for step 2. So some guidelines say routine plex is not recommended for everyone. There's a large trial that showed no reduction in death or end-stage kidney disease overall. Here's that trial in the New England Journal of Medicine if you want to read it. The KDIGO 2024 guidelines said in diffuse alveolar hemorrhage with hypoxemia, plex can be considered alongside steroids, right? And then in anti-GBM, they're usually going to start plex until the antibodies are undetectable. Okay. If there's ANCA positive plus anti-GBM overlap, right? The patient could have multiple things going on. We could add plex to initial therapy, right? So for anti-GBM, if you're going to add plex, you go until the antibodies are undetectable, right? And so the KDIGO 2024 guidelines are suggesting it as of now, even though there's kind of conflicting evidence, okay? So let's put it all together. So our same patient from the initial case is started on therapy with IV steroids, cyclophosphamide, and plex, okay? What is the toxic metabolite of cyclophosphamide called? What medication can help sequester this toxic metabolite? And what is a complication of this metabolite building up over time? So cyclophosphamide, what's the toxic metabolite? What medication could I give with cyclophosphamide to help sequester that toxic metabolite? And what are some complications, the major complications of this toxic metabolite building up over time? So take a second, pause your screen and think about it. So the major breakdown product of cyclophosphamide is called acrolein. Acrolein is extremely toxic to the bladder and to the kidneys, okay? I can give what's called mesna. So here it is, mesna, sodium 2. I'm not even going to try to sulfanyl, ethanol, sulfonate. We just call it mesna. It can help bind up the acrolein, okay? When acrolein builds up Over time, it can lead to hemorrhagic cystitis and bladder fibrosis. And then over time, it can actually lead to bladder cancer, right? So the major complications of cyclophosphamide over time, right? It can occur 10, 20, 30 years down the road is we could have bladder cancer, right? Which is obviously extremely detrimental. And then earlier on, we could potentially get hemorrhagic cystitis and bladder fibrosis, right? So it's acrolein, right? This is a very good step one question. What's the toxic metabolite? It's acrolein, right? What could we give to stop that? It's mesna, right? Remember, cyclophosphamide is like an alkylating agent, right? That's essentially its mechanism of action. Another very high yield concept or side effect of cyclophosphamide I would know is it can cause SIADH, right? SIADH is a story for another day. I have a whole lecture on hyponatremia where I go into SIADH. But I would know for the sake of your step exams, right? Cyclophosphamide it's classically a chemotherapeutic agent, can be used as an induction agent in a lot of these rheumatological diseases. It is an alkylating agent, okay? It can, its toxic metabolite is called acrolein. We can give mesna to kind of bind up acrolein. If the acrolein builds up too high, we can get hemorrhagic cystitis, bladder fibrosis, and bladder cancer, okay? I think that is what I've got for you. So again, if you want to read more, here's a one of the best review articles for pulmonary renal syndrome, right? So again, pulmonary renal syndrome, quick recap. You want to think about it in a patient who has systemic rheumatological findings, right? Potentially, okay? If it's a vasculitis, you might see this. So you think about fever, weight loss, malaise. We think about things like palpable purpura when we think about our small vessel vasculitis. We think about hemoptysis plus hematuria, proteinuria, RBC CAS, right? That's when you start to, okay, you're like, all right, they're losing blood, they're coughing it up, and they're peeing it out, right? And their pee, they have, on microscopy, they have red blood cell CAS. You're like, all right, glomerulonephritis and potentially diffuse alveolar hemorrhage, okay? First things first, let's do our ABCs. Let's get a chest x-ray. Let's see, do we see the bilateral diffuse infiltrates, right? If so, and the patient is unstable, right, we got to do we got to stabilize them, and then we got to do a bronchoscopy with BAL. If the BAL comes back with progressively and sequentially increased amount of bloodier aliquots, we can then diagnose diffuse alveolar hemorrhage. So it's a combination of diffuse alveolar hemorrhage plus the glomerulonephritis. We're like, holy crap, this is pulmonary renal syndrome, right? It falls into three big buckets. We have our ANCA-associated vasculitis or posse-immune glomerulonephritis. So that would be GPA, MPA, plus or minus eGPA. Our GPA tends to be C-ANCA and PR3 positive. Our MPA and eGPA tend to be P-ANCA and MPO positive. A next bucket would be anti-glomerular basement membrane disease, which tends to be anti-GBM positive and have linear IgG on immunofluorescence in the kidney biopsy, right, on the glomerular basement membrane. We tend to see this in relatively younger males, right, with hemoptysis, hematuria. And then the third bucket would be immune complex deposition, right? So things like lupus, IgA vasculitis, cryoglobulonemic vasculitis, things along those lines, right? Those immune complexes can deposit into the kidney and the lungs and cause us pulmonary renal syndrome. After you stabilize the patient, you made the diagnosis of DAH, we need to start IV steroids plus an induction agent like cyclophosphamide or rituximab. If they have anti-glomerular basement membrane disease, we can add on Plex, right? So plasma exchange. If we're adding Plex, we go until the anti-GBM antibodies are undetectable. That would be the level I would understand for step 1 and step 2. Obviously, there's more nuance as you progress through your medical career. So let me know if you have any questions. Send me an email, and I'll see you in the next one.